Welcome to the Hospital Medicine Unplugged podcast. Today, we are initiating a comprehensive clinical deep dive into the contemporary management and the highly intricate pathophysiology of acquired aplastic anemia.
Right, and as a practicing physician, you frequently encounter patients presenting on the wards with unexplained pancytopenia. Distinguishing an immune-mediated marrow failure from other etiologies, that is a critical diagnostic juncture.
It absolutely is. So, to provide you with the most current evidence-based framework, we have synthesized recent literature spanning updates from the NEJM, blood, and leukemia.
Yes, and we are also going to heavily integrate the newly released 2025 American Society of Hematology Clinical Practice Guidelines alongside the 2024 British Society of Hematology Guidelines.
Our primary educational mission for this deep dive is to really facilitate an evolution in your clinical mental model regarding this disease.
Exactly. We need to transition away from the historical, somewhat simplistic paradigm of aplastic anemia as merely an empty marrow space or a generic bone marrow failure.
Instead, you should conceptualize this disease as a highly complex, dynamic landscape.
It is characterized by targeted immune-mediated destruction, active clonal selection, and a sophisticated interplay of targeted therapeutic interventions.
This paradigm shift is of paramount importance for you as hospitalists and hematologists managing these complex patients.
It is. The reason we are examining this topic with such granularity today is that both the therapeutic algorithms and the prognostic outlook for acquired aplastic anemia have shifted dramatically.
Historically, this diagnosis carried a pretty bleak prognosis. It was often managed with purely supportive care or untargeted immunosuppression that yielded highly heterogeneous results.
Today, however, our therapeutic approach requires a highly nuanced understanding of the underlying molecular and immunological mechanisms. We are no longer simply attempting to suppress a hyperactive immune system with blunt instruments.
Right. We are now manipulating specific cytokine pathways. We are leveraging targeted receptor agonists and strategically anticipating long-term clonal evolution.
Understanding the exact mechanisms of immune escape and the genomic architecture of the surviving hematopoietic stem and progenitor cells, that is what will allow you to optimize therapy.
It allows you to accurately stratify patient risk and appropriately time the transition toward definitive procedures, such as hematopoietic stem cell transplantation.
But to establish a rigorous foundation for this deep dive, we first need to address the diagnostic framework.
Let us start right there at the bedside. When you admit a patient with profound pancytopenia, calculating the severity fundamentally dictates all subsequent management decisions.
The Camitta criteria.
Exactly. The Camitta criteria remain the absolute gold standard for classifying the severity of acquired aplastic anemia.
And the diagnosis of severe disease requires demonstrating a bone marrow cellularity of less than 25% on biopsy.
But that histopathological finding must be correlated with profound peripheral cytopenias.
Precisely. The patient must meet at least two of the following three peripheral blood criteria. First, an absolute neutrophil count of less than 500 per microliter.
Second, a platelet count of less than 20,000 per microliter.
Or third, an absolute radic count of less than 60,000 per microliter.
You must calculate these numbers meticulously upon admission.
And we also have to distinguish a crucial subcategory, which is very severe aplastic anemia.
This is defined by an absolute neutrophil count of less than 200 per microliter.
Clinically, this places the patient at an extraordinarily high risk for overwhelming bacterial and fungal infections.
But why do we adhere so strictly to these specific numerical thresholds delineated by the Camitta criteria?
We rely on them because this classification system is the fundamental gateway for all therapeutic decision-making in both the inpatient and outpatient settings.
When you classify a patient as having severe or very severe aplastic anemia, you are immediately mobilizing a complex, high-acuity treatment algorithm.
The severity of the cytopenias, particularly the depth of the neutropenia, directly dictates your next steps. It combines with the patient's chronological age and the availability of a suitable human leukocyte antigen-matched donor.
So, if a patient does not meet these stringent criteria and falls into the category of non-severe aplastic anemia, how does our approach change?
It changes significantly.
Are we still mobilizing those advanced therapeutics?
Generally, no. For non-severe cases, the approach is often watchful waiting or less intensive supportive care.
Because the risks of our advanced therapeutics, like intense immunosuppression or transplantation, may outweigh the benefits in a marrow that is still partially functioning.
Correct. Therefore, calculating the absolute neutrophil count and accurately determining the absolute radic count are indispensable steps.
You must routinely execute these calculations when evaluating these patients upon admission, as it completely forks your decision tree.
It really does.
So if you have these strict cutoffs identifying the absolute lack of cells, the next obvious question for a clinician standing at the bedside is to ask why the marrow is empty in the first place.
Right. We used to think of aplastic anemia as just an empty factory, but recent data shows it is actually an active war zone.
What exactly is driving this destruction?
The primary mechanism driving acquired aplastic anemia is the immune-mediated destruction of hematopoietic stem and progenitor cells.
This is an active, targeted autoimmune assault, not a passive failure of the marrow space.
The specific cellular mediators orchestrating this destruction are cytotoxic T cells.
Upon activation by an unidentified autoantigen, these T cells undergo clonal expansion.
They then infiltrate the marrow and secrete an abundance of type 1 cytokines.
And when we talk about those type 1 cytokines, the literature specifically points to interferon-γ and tumor necrosis factor alpha, correct?
Yes, interferon-γ and tumor necrosis factor alpha are the primary drivers.
How exactly do these cytokines dismantle the hematopoietic infrastructure once they flood the marrow microenvironment?
When interferon-γ and tumor necrosis factor alpha saturate the microenvironment, they actively trigger a downstream intracellular cascade.
These type 1 cytokines bind to their respective receptors on the surface of the hematopoietic stem cells.
This binding activates the Janus kinase and signal transducer and activator of transcription pathways.
Specifically, we are talking about the JAK-STAT signaling cascade.
That intracellular signaling heavily upregulates the expression of the Fas receptor, also known as CD95, on the surface of the stem cells.
And concurrently, the activated cytotoxic T cells are expressing the Fas-ligand.
I have heard this Fas-ligand pathway described almost like a cellular self-destruct button that the T cells are actively pressing.
That is an excellent clinical analogy. When the Fas-ligand engages the Fas receptor, it induces receptor trimerization.
This leads to the recruitment of the Fas-associated death domain and the subsequent activation of the caspase cascade.
This cascade terminates in rapid cellular apoptosis.
This relentless T cell-mediated apoptotic drive is what decimates the bone marrow compartment, resulting in the profound hypercellularity you observe clinically.
That detailed cellular mechanism perfectly sets up one of the most fascinating areas of recent research.
The 2025 data published in Leukemia highlights a massive paradigm shift regarding the mechanism of immune escape.
As the cytotoxic T cells flood the marrow with interferon-γ, the suppression of progenitor cells is not entirely uniform.
What exactly did this research elucidate about which cells survived this assault?
The research shows that interferon-γ selectively suppresses the progenitor cells that express human leukocyte antigen, or HLA class I molecules.
Crucially, this cytokine assault notably spares HLA-lacking cells.
The immune system is essentially enforcing a Darwinian selection process within the bone marrow.
The cytotoxic T cells rely on the HLA class I molecules on the surface of the stem cells to present the target autoantigen.
So when a subset of stem cells spontaneously loses HLA expression, they effectively become invisible to the predatory T cells.
We know this often happens through a somatic mutation resulting in a loss of heterozygosity at the chromosome 6p21 locus, which houses the HLA genes.
What we are really seeing is the cell shedding its ID badge.
Exactly. Without that ID badge, the T cells simply do not recognize the progenitor cell as a target.
Because the interferon-γ-mediated suppression is highly targeted toward HLA-expressing cells, the HLA-lacking cells are spared from apoptosis.
They subsequently proliferate, attempting to fill the massive hematopoietic void.
As a direct clinical consequence, this environment exerts immense selective pressure.
We now observe this phenomenon of HLA-lacking cells in approximately 30% of patients with aplastic anemia.
While this allows for some degree of hematopoiesis to recover, does it not mean the patient's blood is now being produced by a mutant, clonally expanded population of stem cells?
Yes, that is the double-edged sword of this immune escape mechanism. You have active clonal selection occurring within the depleted marrow space.
Furthermore, you must also consider the role of regulatory T cells, or TREGs, in this environment.
During active, severe aplastic anemia, the TREG population is significantly decreased.
This removes the natural brakes on the autoimmune response, allowing the cytotoxic T cells to run rampant.
But as the patient responds to therapy and achieves a hematologic response, we observe a corresponding change in that TREG compartment, correct?
We do. We see a quantitative and functional restoration of the TREGs as the marrow recovers.
This underscores the dynamic immunological balance you are attempting to restore when you initiate treatment.
It is not just about stopping the bad actors. It is about restoring the immune system's intrinsic regulatory mechanisms.
This deep understanding of the active immune destruction brings us to a major paradigm shift in treatment.
I want to discuss the expanding role of eltrombopag.
Historically, the undisputed standard of care for severe aplastic anemia in patients ineligible for upfront transplant was intense immunosuppressive therapy.
We specifically utilized horse antithymocyte globulin combined with cyclosporine.
That combination was the bedrock of therapy for decades.
However, a massive advancement in our therapeutic armamentarium has been the addition of eltrombopag to this regimen.
This shift is primarily driven by the landmark RACE trial.
The data from this trial are unequivocal and strictly dictate current practice for hospitalists and hematologists.
Let us meticulously review the outcomes from the RACE trial because the numbers are staggering.
The complete response rate at 3 months was 22% for patients receiving the addition of eltrombopag.
This is compared to only 10% for those receiving standard immunosuppression alone.
Furthermore, the overall response rate at 6 months reached 68% with eltrombopag.
Versus 41% without.
The acceleration of recovery is perhaps the most critical metric for you on the wards.
Impressively, the median time to first response was accelerated significantly.
It occurred at 3.0 months with eltrombopag,
compared to 8.8 months in the control group.
When you analyze the magnitude of these results, it becomes abundantly clear why this has altered international treatment algorithms.
Let us translate those trial numbers into clinical reality. Is a complete response at 3 months of 22% really that impactful?
It is profoundly impactful. Going from 10% to 22% translates directly into reduced transfusion dependence.
It means fewer hospital admissions for febrile neutropenia, fewer invasive fungal infections, and a profound improvement in patient quality of life.
The reduction in the median time to first response from 8.8 months down to 3.0 months is clinically vital.
Because during those intervening 5 to 6 months of profound cytopenia, your patients are at their absolute highest risk for fatal infectious or hemorrhagic complications.
Every month we can shave off that waiting period is a month we're protecting them from a lethal hospital-acquired infection.
Exactly. Consequently, the 2025 ASH Clinical Practice Guidelines conditionally recommend this triple therapy.
They advise adding eltrombopag to standard immunosuppressive therapy for both adult and pediatric patients presenting with severe or very severe disease.
But to utilize this agent optimally, you must understand its mechanism of action in this specific context.
We broadly classify eltrombopag as a thrombopoietin receptor agonist.
We frequently use it for ITP to stimulate platelets.
But its role in aplastic anemia extends far beyond simply stimulating megakaryopoiesis. How exactly does it operate within this highly toxic marrow space?
It functions quite uniquely. Eltrombopag binds to the transmembrane domain of the CMPL receptor on multipotent hematopoietic stem cells.
It actively bypasses the traditional extracellular binding site that endogenous thrombopoietin uses.
This intracellular activation directly stimulates broad hematopoiesis across all cell lines, not just platelets.
And recent evidence suggests it also possesses potent immunomodulatory properties.
Specifically, it acts to interrupt the interferon-γ-mediated inhibition of stem cells we discussed earlier.
It is effectively neutralizing the toxic marrow microenvironment while simultaneously whipping the surviving stem cells into production.
That is the leading hypothesis for its profound efficacy.
While a combination of antithymocyte globulin, cyclosporine, and eltrombopag represents a formidable medical approach, we have to discuss definitive therapy.
The potentially curative therapy remains hematopoietic stem cell transplantation.
Navigating the decision tree between aggressive immunosuppressive therapy and upfront transplantation requires careful clinical judgment.
The 2025 ASH guidelines provide highly nuanced, age-stratified recommendations for this decision.
As a hospitalist, this age stratification is the crucial mental map you will want to lean on when consulting hematology.
For your patients under 20 years of age, the guidelines recommend either a matched sibling donor transplant or immunosuppressive therapy.
For the demographic of patients aged 20 to 40 years old, the recommendation shifts slightly.
They suggest either a matched unrelated donor transplant or immunosuppressive therapy.
However, as age increases, the risk of transplant-related mortality shifts the balance significantly.
Thus, for patients over 40 years old, the guidelines explicitly state that immunosuppressive therapy is preferred over a matched unrelated donor transplant.
Let us introduce a challenge here. If a transplant effectively cures the disease and drops the risk of secondary leukemia to essentially zero, why are we prioritizing immunosuppressive therapy in the older demographic?
Are we not just delaying the inevitable need for a new marrow?
It is a delicate balance of competing mortalities. The biological age of the patient serves as a surrogate for their ability to tolerate intensive conditioning regimens.
Older patients have a much harder time enduring the inevitable and severe complications of graft versus host disease.
Immunological senescence and the increased incidence of refractory graft versus host disease significantly diminish the survival advantage of unrelated donor transplantation in that over 40 group.
That makes perfect clinical sense. And what about haploidentical transplants?
The ASH guidelines assert that immunosuppressive therapy is suggested over haploidentical transplantation across all age groups in the upfront setting.
The risks of a half-matched donor currently outweigh the benefits when we have highly effective triple therapy immunosuppression available.
Correct. But it is also fascinating to compare the ASH framework with the 2024 British Society for Hematology guidelines.
The BSH guidelines largely align on the principle that unrelated donor transplants in adults should predominantly be considered only after a documented lack of response to an initial course of immunosuppression.
Yet the BSH introduces a really pragmatic caveat for a specific clinical scenario.
They support utilizing a matched unrelated donor transplant upfront for young adults who present with overwhelming severe infections.
In a scenario where a patient is battling relentless sepsis, waiting 3.0 months for an L-thrombopag response might literally be fatal.
Exactly. Provided a fully matched donor is immediately and readily available, the BSH recognizes that you may need to force a rapid marrow replacement.
This highlights the absolute necessity of individualizing your treatment approach based on the immediate clinical acuity of the patient.
Guidelines provide the map, but you must still navigate the terrain of the patient right in front of you.
As we navigate these treatment pathways, we must systematically address one of the most critical pathophysiological associations in this disease.
We need to talk about the connection to paroxysmal nocturnal hemoglobinuria, or PNH.
You must recognize a striking statistical reality. Up to 50% of all patients diagnosed with acquired aplastic anemia will be found to harbor a PNH clone.
Because this association is so prevalent and clinically consequential, the 2025 ASH guidelines have issued a firm conditional recommendation.
They state you must routinely test all patients presenting with severe or very severe aplastic anemia for the presence of a PNH clone.
This recommendation applies completely irrespective of the patient's age.
This screening is no longer an optional add-on. It is a mandatory component of your initial diagnostic workup.
To execute this mandate effectively on the wards, you need to know exactly what to order and why.
Historically, screening methods lacked the sensitivity to detect the minute clones frequently present in the setting of aplastic anemia.
What is the absolute diagnostic gold standard we are using today to find these cells?
Today, the gold standard is high-sensitivity flow cytometry utilizing FLAL-AR.
FLAL-AR stands for fluorescent aeroleucin.
This highly specific assay targets the CD55 and CD59 surface proteins on the cells.
Aeroleucin is actually a bacterial toxin that binds directly and specifically to the glycosylphosphatidylinositol, or GPI, anchors on the surface of hematopoietic cells.
CD55 and CD59 are vital complement regulatory proteins that require this GPI anchor for surface attachment.
In the absence of the anchor, these protective proteins are absent.
So by utilizing FLAL-AR-based flow cytometry, your laboratory can detect even microscopic populations of GPI-deficient cells.
That is precisely how it works. The clinical introduction of the FLAL-AR assay has profoundly impacted our diagnostic yield.
It significantly boosted detection rates for these very small clones from a historical baseline of 8.3% all the way up to 18.2% in the aplastic anemia cohort.
When you order this test, you are not merely looking for classic hemolytic PNH.
You are executing a highly sensitive search for a specific molecular signature within the failing bone marrow.
What makes the detection of this molecular signature so fascinating and highly counterintuitive is its prognostic significance.
In classical hematology, detecting a mutant clone typically portends a poorer outcome. We usually associate clones with impending malignancy.
However, in the precise context of acquired aplastic anemia, the revelation of a PNH clone actually serves as a highly favorable prognostic marker, regardless of how small it is.
The data validating this are incredibly robust and counter to our usual clinical instincts.
Patients harboring a PNH clone demonstrate a superior response rate to immunosuppressive therapy,
They achieve a response in 78% of cases.
compared to only 50% in those lacking the clone.
Furthermore, if these patients eventually proceed to transplantation, their response is similarly enhanced, showing a 97% success rate.
Versus 77%.
Crucially, the presence of the PNH clone also correlates with a significantly lower longitudinal risk of the disease progressing to myelodysplastic syndrome.
But how do we reconcile this? Why does a cellular mutation, one that causes a known disease like PNH, impart a massive survival advantage in these patients?
To understand this, you must return to the mechanism of immune escape we detailed earlier.
The presence of the PNH clone is defined by a somatic mutation in the PIGA gene.
This gene is absolutely essential for synthesizing that GPI anchor.
Without this anchor, the stem cells become completely GPI negative.
In the highly toxic autoimmune microenvironment of aplastic anemia, the cytotoxic T cells are actively seeking and destroying normal, healthy hematopoietic stem and progenitor cells.
But for reasons that continue to be investigated at the molecular level, these GPI negative stem cells successfully evade the targeted T cell mediated autoimmune attack.
Much like the HLA-lacking cells we discussed, the PIGA-mutated cells possess a potent survival advantage.
They have effectively constructed a cellular shield against the interferon-γ and tumor necrosis factor alpha assault.
Therefore, when you detect a small PNH clone in your patient, you are identifying a subpopulation of stem cells that is adapted to survive the immune destruction.
This intrinsic resilience is exactly what translates clinically into that improved 78% response to immunosuppressive therapy.
It explains the extraordinary 97% response to transplantation.
And because this specific clone is incredibly stable, it offers profound protection against the more malignant progression to myelodysplastic syndrome down the line.
That protective effect provides a natural transition to the most daunting aspect of managing this disease over the span of a patient's life.
We must discuss the long-term complications, specifically clonal evolution and the complex molecular landscape.
While we have made tremendous strides in short-term survival, the threat of clonal evolution remains the most serious long-term sequela you will face.
We are talking about evolution into secondary myelodysplastic syndrome or acute myeloid leukemia.
This evolution occurs in roughly 10 to 20% of patients by the 10-year mark following their initial treatment with immunosuppressive therapy.
When analyzing the risk paradigms, you must carefully contrast the outcomes based on the initial therapeutic modality chosen.
The 10-year cumulative incidence of secondary myeloid neoplasms sits at approximately 11.6% for those patients managed with immunosuppressive regimens who did not receive a transplant.
In stark contrast, those patients who underwent upfront hematopoietic stem cell transplantation faced essentially zero risk of this specific clonal evolution.
Their entire diseased, mutation-prone hematopoietic compartment was completely replaced.
This massive disparity in long-term outcomes necessitates a rigorous evaluation of the molecular landscape residing within the bone marrow.
As you monitor these patients longitudinally on the outpatient side, you must recognize that clonal hematopoiesis is incredibly common.
In fact, it is detected in approximately 50% of all aplastic anemia patients.
However, not all somatic mutations carry the same prognostic weight.
You must differentiate between high-risk and favorable molecular profiles when you review their next-generation sequencing panels.
Mutations in epigenetic modifiers, specifically DNMT3A and ASXL1, are strictly designated as high risk.
When you detect these specific mutations, what does it signal for the patient's trajectory? It is not just an incidental finding.
Detecting DNMT3A or ASXL1 indicates a significantly higher risk of rapid clonal expansion over time.
This leads directly to worse overall outcomes and a high probability of rapid progression to secondary myelodysplastic syndrome or acute myeloid leukemia.
You have to monitor these patients with extreme vigilance.
Conversely, we observe favorable mutations, most notably in the BCOR and BCORL1 genes.
And of course, the PIGA mutations we just discussed fall into this favorable category.
These favorable alterations correlate with stable or even decreasing clone sizes over time.
They predict superior responses to immunosuppressive therapy and a much lower propensity for malignant transformation.
As the managing physician, you must systematically evaluate the specific predictors for clonal evolution to accurately risk stratify your patients.
The established risk factors include an older age at initial presentation and a documented lack of response to primary immunosuppressive therapy.
Furthermore, the presence of the high-risk mutations like DNMT3A and ASXL1, or the presence of multiple concurrent mutations with a high variant allele frequency, heavily predict evolution.
When a patient does unfortunately evolve from aplastic anemia into a secondary myelodysplastic syndrome or acute myeloid leukemia, the clinical reality is grim.
The disease is notoriously aggressive.
These post-aplastic anemia malignancies frequently display profoundly high-risk cytogenetic features.
They most commonly involve chromosome 7, presenting as monosomy 7 or deletion 7q, along with highly complex chaotic karyotypes.
The survival data for this evolved state severely reflect its aggressive nature.
We see a 5-year overall survival of only about 40% if managed without transplant.
Fortunately, this can be improved to a 64% 5-year overall survival if the patient is able to undergo a subsequent hematopoietic stem cell transplantation.
The recognition of these risk factors and the aggressive nature of monosomy 7 or deletion 7q should fundamentally alter your approach to long-term follow-up.
When evaluating a patient years after their initial response to immunosuppression, you cannot be complacent.
The new onset of macrocytosis, a subtle downward trend in the platelet count, or the appearance of circulating blasts must immediately sound the alarm.
You cannot assume these subtle changes represent a simple relapse of their benign aplastic anemia.
These findings must immediately prompt a comprehensive reevaluation, including a full bone marrow biopsy with comprehensive cytogenetic and molecular profiling.
The precipitous drop in survival to 40% without a transplant underscores the absolute imperative to identify this evolution early.
If you detect high-risk mutations like DNMT3A or ASXL1 on that follow-up marrow, particularly with an expanding variant allele frequency, what is the next step?
You do not just wait for the blast to show up in the peripheral blood.
You must proactively initiate discussions regarding transplantation long before overt leukemic transformation occurs.
Switching a patient with secondary complex karyotype leukemia to a curative transplant is fraught with immense clinical challenges.
The conditioning is harder, the relapse risk is higher, and the overall mortality skyrockets once they cross that leukemic threshold.
Synthesizing all of this complex data, we must clearly define the modern prognostic outlook and specific clinical considerations for your daily practice.
The contemporary survival rates represent a genuine triumph of targeted medical therapy.
Overall, 5-year survival for acquired aplastic anemia now exceeds 80% across broad cohorts.
Even more remarkably, recent studies evaluating the incorporation of eltrombopag into frontline regimens have demonstrated an astonishing overall survival rate of up to 97%.
But as we discussed, this short-term success must not breed complacency in your clinical monitoring.
Rigorous longitudinal surveillance is absolutely non-negotiable for these patients.
Because the relapse rate following an initial response to immunosuppressive therapy remains highly significant, hovering at approximately 22%.
And that is alongside the ever-present 10 to 20% risk of clonal evolution we just analyzed.
You are managing a chronic dynamic condition, not just treating an acute episode.
Furthermore, when you are initially establishing the diagnosis and prognosis, there is an absolute clinical necessity to definitively exclude inherited bone marrow failure syndromes.
This is especially critical when you are evaluating patients in the pediatric, adolescent, or young adult demographics.
Though it remains highly relevant even in older adults presenting with atypical or syndromic features.
We are talking about syndromes like Fanconi anemia or dyskeratosis congenita.
Misdiagnosing an inherited syndrome as acquired aplastic anemia is a catastrophic error.
It will lead you to expose these vulnerable patients to the intense DNA-damaging conditioning regimens of a standard transplant, or subject them to entirely inappropriate immunosuppressive therapy that will only cause harm.
You must meticulously follow the National Comprehensive Cancer Network guideline recommendations for a comprehensive evaluation.
This evaluation must systematically include rigorous germline genetic testing.
You must perform precise telomere length testing in peripheral blood leukocyte subsets.
Finally, you must order dedicated chromosomal breakage studies utilizing agents like diapoxybutane to further rule out underlying DNA repair defects.
Only after definitively excluding these inherited etiologies can you confidently proceed with the therapeutic algorithms for acquired disease we have detailed today.
As we conclude this deep dive, we want to synthesize these immense advancements into a final, critical perspective for your hospital practice. We have traversed a massive amount of clinical ground today.
We moved from the basic diagnostic thresholds of the Camitta criteria straight into the destructive T-cell-mediated pathophysiology driven by type 1 cytokines.
We explored the evolving therapeutic landscape defined by the RACE trial data and the highly nuanced age-stratified application of hematopoietic stem cell transplantation.
We also navigated the complex molecular interplay of the PNH clone and the ominous threat of clonal evolution driven by somatic mutations.
The overarching mandate for you as a clinician is to apply this highly sophisticated, molecularly driven understanding to every patient you encounter with severe cytopenias.
We have to move past the idea of the empty marrow and recognize the active evolutionary battleground we are attempting to manage.
To leave you with a final provocative thought that bridges our daily clinical reality with broader biological principles.
Consider deeply how the phenomenon of clonal evolution in aplastic anemia challenges our traditional binary understanding of pathophysiology.
In classical hematology, we view a somatic mutation like PIGA as strictly pathogenic. We see it as the fundamental driver of the hemolytic destruction in paroxysmal nocturnal hemoglobinuria.
Yet, in the specific, highly toxic context of severe aplastic anemia, this exact same mutation acts as a profound, life-saving evolutionary adaptation.
It functions as a resilient cellular shield, granting stem cells the unique ability to evade a lethal autoimmune attack.
It flips our entire understanding of good versus bad mutations on its head.
This forces us to ask a profound question for the future of medicine.
How might this radical concept of acquired protective somatic mutations reshape our future approach to targeted immunomodulatory therapies?
Could we eventually harness or even genetically engineer similar mechanisms of targeted immune evasion to protect vital cellular compartments across a much wider spectrum of severe autoimmune and hematologic disorders?
It is an incredible concept to ponder as you integrate these complex dynamics into your clinical reasoning on the wards.
We hope this framework empowers you to manage these challenging cases with a deeper, more mechanistic confidence. Thank you for joining us for this deep dive into the clinical management and molecular intricacies of acquired aplastic anemia.